I think we're in a really exciting time right now with CLL. I really think that chemotherapy or chemoimmunotherapy, it's a dying art, which is insane to say because, when Rituxan came out and we started pairing it with, other chemotherapy drugs, it changed the landscape. It was the hot new item on the block. And to see where we've come from FCR and BR to now looking at, in some cases, all oral therapy or, looking at drugs that we're using MRD to determine, okay, you can go off now. It's fascinating. And I think that as time goes on, possibly even in the next year, we're going to know that, okay, 3 drugs, AVO is better than, VO is better than Acala by itself. It's just, we have so many options now, which I think is just, if you are, a medical oncologist specifically in the field of CLL, or anything for that matter, just the changes going on. And, you go to a meeting and you come back supercharged because you have all these other options to offer your patients that you didn't have, even 18 months ago. So I think it's a great time. CLL is changing constantly. It's hard to keep up. You could go to the guidelines, every 3 weeks, and a different drug is probably going to change it in the latter. I think we're at a good holding point right now where I think that we're pretty set, with the selection order of drugs such as acalabrutinib plus or minus obinutuzumab, venetoclax plus obinutuzumab. But if you don't spend time going to meetings, or if you don't spend time, reading all the emails we get with updates, or going to the NCCN guidelines, it's really hard to know what to choose, especially when you're in a community oncology practice where you're seeing 15 different cancers. It's really, really hard to know the newest and latest, greatest data on every single, disease you're treating. So my advice specifically would be to really know your patients. We know that a majority of our patients, I believe the statistic is 89% of newly diagnosed CLL patients are going to have at least one major comorbidity. So vascular disease, atrial fibrillation, high blood pressure. Do they have an existing rheumatologic disorder? Do they have pain every day already? You need to know those things. In the day-to-day when you're seeing, 25 plus patients in clinic, you sometimes forget the little details of your patients. And I think, number one, you need to know your patients and what their other medical issues are when you're looking at your selection of medicine. The other thing is cytogenetics. Unfortunately, we know that acalabrutinib, is highly successful in the high-risk cytogenetic groups. But it's really important, especially with some pathology labs, they're not routinely testing all the different, genetic mutations. And that's really, really important to know, especially when you're looking at overall response rate and which drugs you're choosing. You don't want to choose FCR if they have a deletion 17p. Now, most doctors are not choosing FCR anymore, but bendamustine, Rituxan still gets selected. And you need to know the data. You need to know the efficacy when you're looking at the other drugs. But you gotta know your patients. Listen to your patients, know their other medical issues, and if you know that, it will guide you towards the best treatment for them.